Welcome to colleagues in India, the distinguished panel, and good evening from a gloomy Oxford. I'm just going to share my screen, and I will focus primarily on prediction. What is happening tomorrow, as if we actually knew. And my thoughts go out to Indian colleagues, not only because I wish that I was in India rather than Oxford, but also because you are struggling so much with the pandemic at the moment. And this is by way of diversional therapy. So thank you to our sponsors. Thank you to IBD-ENC and colleagues. I start with the disclosures, which seem to increase in number as the years go by. And let's define what we're speaking about. That is the severe attack. On the right at the top, you have Sidney Truelove. And then below that, you have Leslie Witts, who's often forgotten, but he was the Regis Professor of Medicine back in the 1950s when these criteria were defined. Diarrhea 6 or more times daily with visible blood, and a tachycardia or a pyrexia or anemia or an ESR more than 30 millimeters of mercury, millimeters per hour. And you've heard me say this many times because the number of criteria, in addition to a bloody stool frequency, correlate with outcome. But things are different in India. And Vineet Ahuja and colleagues at AIMS have investigated whether this the Truelove and Witts criteria apply in India, and they've removed the hemoglobin. As you can see, the criteria just bloody diarrhea, tachycardia, temperature, and a high ESR, or indeed a CRP for that matter, define the severe attack. And the way they did it was just to take patients with acute severe colitis admitted to the to AIMS according to original criteria, and they found that excluding hemoglobin didn't classify any patient as having acute severe colitis, and that probably reflects the mean hemoglobin in the Indian population. And indeed, Vineet went on to investigate whether you could dispense with clinical criteria altogether. And he took almost 100 further patients with acute severe colitis and just checked their fecal calprotectin levels. And if you've got a very high fecal calprotectin, almost 800 micrograms per gram, that had excellent diagnostic accuracy for acute severe colitis. And I make no apologies for dwelling on the definitions, because all too often patients, or sometimes their physicians, will delay admission for intensive treatment until a late stage, and we need to look at outcomes, because it's the outcomes, colectomy, hospital discharge, survival, which matter. Now, work that we did in Oxford some little while back showed that about a quarter of our patients in Oxford developed acute severe colitis. So that's a substantial number. Originally, it was thought to be only about 1 in 10, 1 in 8, but in fact, it's 1 in 4. And what's also interesting is that we went on to show that the colectomy rate in all patients with ulcerative colitis was just 12%, 12.4%. And if they were the 3/4 never admitted with acute severe colitis, the colectomy rate was only 3%, just above 3%. Whereas those admitted at least once with acute severe colitis, it's 40%. And that tells me that those patients with acute severe colitis have a worse long-term outcome. I'm talking about that 40% colectomy rate, not during that index admission with acute severe colitis, but at any stage, because of course colectomy only happens once. And the number of times admitted, guess what, your colectomy rate goes up. And the colectomy rate hasn't changed, or had not changed, for 40 years until Dan Turner did a review some almost 15 years ago. But it has perhaps now. The reason that we get concerned is that patients die. Indeed, it was the death of a young patient that with colitis that made Sidney Truelove start investigating the condition, which was poorly defined back in 1950. And the larger the volume hospital, then the lower the colectomy rate. These are Canadian data from Gil Kaplan. And it's also noted that the number of pre-operative admission days, just in the top right there, the longer the admission before colectomy, the longer of time in hospital, the longer the time for physicians prevaricating before deciding about colectomy, the higher the mortality, the higher the morbidity. That's an important. This is what we're playing with, and in many hospitals, then the numbers of patients admitted with acute severe colitis are relatively few, depending on how often a consultant is on call. It may only see 1 or 2 cases a month, and therefore only be faced with a decision about colectomy 2, 3, 4 times a year. And therefore, we need better predictors of outcome. Unfortunately, help is at hand, either at diagnosis, on admission, at endoscopy, after 3 days, or on discharge. And there are new indices, which is refining the art. We developed an index which predicted the likelihood of acute severe colitis based simply on the extent of disease in CRP and hemoglobin at diagnosis. And we found that if patients had pancolitis or extensive colitis, a high CRP and a low hemoglobin at diagnosis, then somewhere between 3/4 and in validated studies, 100% went on to have acute severe colitis. These are the data validated in Cambridge and Uppsala after our development cohort in Oxford. And you can see that every patient who met those simple criteria at diagnosis went on to have an episode in Cambridge. And whilst the numbers were larger in Uppsala and the admission rate was very much lower, they still held out for prediction. But they don't seem to work in China. And we just repeated this in last year. And you can see that applying the same criteria in China, that if you look at the purple bars where all hospitals contributing, 3 hospitals contributing, then it would just less than 40% predictive value for admission with acute severe colitis. So not very good and needs to be refined. We went on and did some machine learning on our data set in Oxford, looking at all using EPR to look at all sorts of criteria and trying to capture the inflammatory burden, because it does seem that the inflammatory burden matters, and we're still not close to having a reliable, reproducible index of knowing who's going to get a bad attack. But it seems that the worse the inflammation is at diagnosis, the more likely at some time in the following 3 years you are to be admitted with acute severe colitis. So what about those patients admitted? Next thing is you want to know, are you going to call on the services of Dr. G.V. Rao and surgery? And in Oxford, we still count the number of additional Truelove and Witts criteria. Of course, in India, if you follow the aims, you remove the hemoglobin, so you've only got 3 additional criteria rather than 4. But you can see that if you have 3 additional criteria, about 50% will go on to have a colectomy, and that's an important message. So the more severe inflammation at admission, the worse the outcome. How do you manage that? Hospitalization, steroids. In red there, if you read the paper in APT on enteral nutrition as adjunctive therapy for acute severe colitis, it seemed to improve, almost double, the responsiveness to steroids. I think that's important, and we've certainly adopted that in Oxford. So we give patients exclusive enteral nutrition if they're admitted with acute colitis. We keep their potassium up, if necessary, with intravenous fluids, and give them hydrocortisone and assess their response. We also give them thromboprophylaxis, and we do some pre-screening bloods in case biological therapy is needed. Now, these data are interesting because they relate to Dan Turner, showing that the colectomy rate, and the full line, if you like, is that big red bar there, really hasn't changed over 40 years. But as I intimated, I'll show you data which suggests that the colectomy rate has reduced in the past decade. We like to reassess patients on the third day, and we use objective criteria because it is so difficult to use clinical judgment to decide. And we use the familiar index developed 20 or even 30 years ago, the CRP of more than 45 and a stool frequency of between 3 and 8 a day on the third day of intravenous steroids predicts about 85% will come to colectomy. Or, of course, if you've got a particularly high stool frequency of more than 8 on that third day. We tried introducing the ulcerative colitis index of severity, which will be familiar to many. You do a flexible sigmoidoscopy on admission because you want to exclude CMV and to assess the severity. And we've shown that if you've got a UCIS of 7 or 8 out of 8, then almost everyone comes to need rescue therapy or colectomy. Although we had death as an outcome, none of our patients died. Vineet's been busy and has shown that using mucosal quantitative PCR for CMV suggests that if you've got more than 2,000 copies per milligram, then it predicts steroid failure. Not terribly accurately, and of course, mucosal quantitative PCR is not universally available. But he has looked at fecal calprotectin UCIS and reckons that if you've got a UCIS of more than 6 on admission, so 7 or 8, and a day 3 fecal calprotectin more than 1,000, these are independent predictors, and this went on to develop what is called the AIMS index. And this simple predictive score, that if you've got the high fecal calprotectin and a UCIS of 7 or 8 out of 8, then the positive predictive value for needing rescue therapy is 93%, which is good and difficult to improve on that. We in Oxford have developed a different index. I'm sorry to blind you with indices, but I think it emphasizes the importance as science progresses to use an index which predicts outcome. And Jax at Sanghi and Vipin Gupta, who was at AIMS and has been spending time in the UK, demonstrated that if you could just capture the UCIS and CRP, then you could predict the outcome. So we looked at consecutive admissions, 130 odd consecutive admissions. We validated it in Queensland, and it's undergoing validation in Delhi. But essentially, if you combined these 4 points, so CRP, which was pretty high, 100 milligrams per liter, and gave you 1 point, an albumin pretty low, 25 grams per liter, and a UCIS, if it's more than 7, is 2 point, UCIS of 4 or more is 1 point. Then if you scored 4, everybody did badly and failed steroids, whereas if you scored 0, then everybody responded, which is all great. And that's in the process of submission at the moment. And if it can be validated in the Gold Coast and India, so we've got 3 continent validation. Well, that's all. That's excellent. There are other indices, and you've just published the use of machine learning. Which is, I would regard as a proof of principle, doing what we were doing, I touched on earlier at diagnosis, but this is using principal component analysis of the electronic data records. And yes, similar things coming out, albumin, CRP, hemoglobin, and whatever. And it's still got to get to the practical stage of practical index, but proof of principle, I think that's where we'll be going and having the machines do it for us. So there are other indices, and I'll just very, very briefly mention them because they all vary on a theme. But my colleagues in Melbourne have tried to remove the observer from the endoscopic observer from the algorithm, and they just use fecal calprotectin and the CRP albumin ratio. They all come down to a theme that if you've got bad inflammation, you do worse, but do use an inductive measure. So what do? You've got an index. You find that it's predicting a poor outcome. Well, you've got to have a discussion with the patient at an early stage about the prospects for modifying the pattern. Is it their first presentation? Is it relapse? Is it relapse despite immunomodulators? And that's when I call on our colorectal surgeons, because they need a discussion early, not as happened last week in a hospital in the Thames Valley after 9 days of intravenous steroids. I almost fell off my chair that they thought about asking for surgery. And of course, the patient was saying thank you, but there must be an alternative. And I think that the message that I've got is that the outcomes are changing. Because whether you use we're using more anti-TNF, we still use a lot of cyclosporin in Oxford, and I know you do in India. It's cheaper, it works as well in 2 randomized controlled trials. But if you look, the purpose of this is to compare the different cohorts over time. And if you look at our original cohort from 25 years ago in the salmon pink, we had a 29% colectomy rate. Then when Lottie Dinnerson looked at it 15 years later, 25%. Crispin Court in the UCIS study, 24%. Now we're down to 15%. So it's halved in that time. And guess what's doubled? It's the use of rescue therapy, and in particular the infliximab use. But I still regard cyclosporin as effective as infliximab. And and here's looking at the outcomes. You can see that none of our patients in the original cohort 25 years ago had infliximab. A quarter did in recent years, and highly significant difference, highly significant reduction in colectomy, and that matters to patients. I'm not going to say anything about surgery, even smart surgery, but I hope your abdomen ends up looking like that with single port surgery and not like the vast laparotomy scar I saw this morning in clinic of a patient who had a colectomy elsewhere. So to conclude and keep to the time, I hope, prevention is best. If you can predict the risk of acute severe colitis at diagnosis, then those are patients who you need to follow and advance therapy at an early stage. We've still got to show the evidence that makes a difference, but it makes logical sense. If you admit a patient with acute severe colitis, and many of the several hundred people on this call will have patients in hospital at this moment in time who've got acute severe colitis, then count the number of true love and Wicks criteria because they relate to outcome. Use endoscopy and fecal calprotectin because if you've got a high UCIS and you've got a very high fecal calprotectin, they're not going to do well. We still use the third day index. And above all, act on those criteria. Contingency planning, get the opinion of a colorectal surgeon when at a timely manner, when there's still an option for medical therapy, but patients can talk about that. Don't ask for a surgeon when it's the end of the line and they've got to operate on a steroid-saturated patient. Use infliximab if they're already on azathioprine. Use cyclosporin if they're azathioprine naive. Don't use both together. Go for colectomy and don't duck difficult decisions. And at some stage, I might escape from this place to warmer climates. Thank you very much indeed.